Hi.
Yes, could you tell us how far you've gone in the brain chemistry, in the what do you call it? The brain scans, yes.
Yeah.
Are you moving ahead on that, or are you studying the chemistry of the brain to get the balance?
Yeah. Yeah, and I should represent this properly because I'm not a neuroscientist. I'm a physician who's trying to bring these medications into the clinic and using them. But that's been a huge development in our understanding of the biology of addiction, is to be able to scan people's brains who've been using drugs and those who haven't, and showing how these changes in the brain are measurable and that the brain is very plastic, and plasticity of the brain and changing, and how prolonged abstinence will bring the brain back to a normal state of functioning. Different areas of the brain that are affected by different drugs. It is a fascinating area of research, and the radiologists that like to scan brains and the animal lab people that like to dissect brains, there's just again a huge implementation science gap to start employing what we've learned and putting that into policy, into medical treatments.
You just say you're trying to get at the cause, not the result, the cause of it.
Yeah, I mean, that's a really good point, because a lot of people talk about prevention, and I don't think I've inspired anyone about the prevention tools that we have. And so many of these things are socially determined, right? The social determinants of health reign hugely large when it comes to these things. Now, anyone can become addicted. West Side families experience this, but of course, we know that horrible life experiences predispose to addiction in later life. The problem, of course, is that elected officials have a 4-year cycle. So to try and do some early intervention thing that's going to bear fruit 20 years from now isn't the most attractive thing. I'll let you try and read that. I'll take another question in the meantime. Go ahead.
I thought your diagram number 3 was really interesting, where you showed corporations having control over the drugs as well.
Yeah.
Marijuana, because it looks to me what's going to be happening in Canada is that the Harper government is allowing medical marijuana to be grown, and what they don't want to see is these kind of backyard growing ops, and they want to make it, my guess is they probably want to make it a pharmaceutical large-scale operation, industrial operation where they can get a lot of taxes from.
Yeah.
What's your prediction in terms of the scale that was on that diagram 3 for what's going to happen when that happens?
Yeah, it's interesting because I think a lot of what's happened with medical marijuana, and for people that have been to some of the cities in California where there's a medical marijuana dispensary on every corner, is really, I think, emerged because of marijuana prohibition. And then there's this thing happening with, in medicine we call it indication creep, where now marijuana is useful for so many things. And I think there's a missed opportunity for government to step back and look at this problem and say, let's all sit around and come up with the best way to manage this. But because it's been so oppositional, you have these other models emerging, and it'll be very difficult to put the genie back in the bottle. I mean, even using alcohol as an example, imagine if the NDP came in and said, we're going to reduce alcohol outlet density, we're going to raise taxes, we're going to reduce branding. People don't want that. So it takes a lot of leadership, and it is tough to put the genie back in the bottle. So I think that there's a real opportunity with cannabis to look at the way that it could be regulated to maximize public health and safety, but whether we'll go down that road, I don't know.
Okay, so we have one question here to repeat the question before answering for the video. I'm not exactly sure. And then this one is regarding the last drug you mentioned, and I'm not sure what the last drug was, by binding to opiate receptors. How does that affect? Dopamine,
probably. Endogenous opiate system. That's a great question.
Mm.
So I thought people would ask about the effects of anti-opioid medications, and I've been spent the whole night talking about dopamine. And basically, when the opioid system is triggered, dopamine is subsequently triggered. So there's a cascade. But the question is, what about our endogenous opioid system? So when you go for a run or you do certain things, you get this nice rush, and that is the endogenous opioid system. And you could think that if you were on this medication, it would take all the joy out of your life. And that question has been asked and answered. And there was a real thinking that, okay, you go on this medication, you've got this stuff sitting on your opioid receptors, it blocks everything else, and you're just sitting there, you can't take joy out of anything. And the studies that have been placebo-controlled looking at this, actually, people still get great enjoyment from food and other things like that. There's no measurable difference. So it's a very good question, and that hasn't really been the case. Sure. I need to repeat the question. Other questions? Sure.
Given the 50% heritability, I think you mentioned in addiction, I'm just wondering if there's any research into genetic counseling as like a prophylactic feed on addiction in the next generation.
Yeah. So the question is about genetics and risk, and could you, a young person tell them that they're genetically predisposed as a strategy for they would be better in their prevention knowing this.
Attention visitors, the time is now past 8 o'clock. Visiting hours are now over. Thank you and have a great evening.
So what's really interesting about all this genetic research is it's extremely helpful and it's great for the scientists, but actually taking a really good history, a physician taking a good history, probably gets you as much information as you need to know. So if someone's, your classic question in medical school is an orphan presents to you and has no family history, and then you're like, oh God, that would have been nice. So usually you know. That would be a study that would need to be done, and I think it could be done. There's no reason that it couldn't be. I don't know if it would make anyone more reassured to know that they have a gene that could make them more predisposed to become addicted. That would be a burden that you might carry. But I don't want to make it sound like this genetic science isn't useful. So this medication, Vivitrol, used to be a once-a-day medication that people had to take, and it didn't work very well because people wouldn't take it. And studies from that pill-taking era showed that there were genes that predicted who would respond really well to that medication. So you could actually do a sort of a personalized medicine approach where you would check this person's human genome and say, yeah, you're a really good candidate for naltrexone because the studies have shown that the genes that you have indicate you'll respond really well to this drug. So I don't want to say that there isn't applications for it, but I'm not sure that sort of genetic counseling in this context would be helpful. I don't want to say that it isn't. It's not my area of expertise, and I think it's a compelling question.
So we have two questions here. The first one is treatment. Treatment centers and recovery houses are not funded or not enough treatment centers. And then it has pillars 3 and 4. Why? Mm-hmm. Second question, which treatment centers are best? Which are getting better?
Yeah. So this is about, the question is about abstinence-based treatment centers. So when someone is using drugs and becomes addicted to drugs, they'll often access medical detoxification. Whereas different drugs, it's different types of detoxification. But oftentimes, for your average person, could end up at a place like Vancouver Detox and stay for a couple days and detox from their alcohol use. That's not going to cure them of their addiction, and the next step on the road to recovery would oftentimes involve going to a residential treatment program. And the question is, what about the quality of these? And in many cases, there's no standards. People go and their welfare check would go to support them being there. And there would be, group therapy and other things. But the quality of care delivered is very...
minimal. It's minimal.
Just the practice patterns across and the diversity with that. I mean, you're probably well positioned to comment on it.
As far as the treatment centers, when I was ready to go in to get treatment, I was looking at a 3-month wait. So, and I was ready then. And they said, well, we can't, there's nothing we can do. We don't have any spaces for you, there's no beds. And I was lucky enough that I had a doctor that said, we'll find you someplace. The next thing you know, I'm being told about this place called The Orchard. And I'm like, whatever you need to do. Little did I know when I got over to Bowen Island and they said, how do you want to pay for this? And they came back and told me my credit card would only take $6,000. My face was like, how much is this? It was close to $17,000, $18,000. I'm still paying it off. I'm almost done. The good thing for me, though, is I tied that into a program so that every time I write that check, it humbles me and makes me remember, thank you, God, for my sobriety. With that being said, there are so many people out there that I know that would like to get into recovery, but there's no spaces for them. And another piece that goes along with this is if I was just, because many times I went to AA and walked out and went, yeah, I mean, this is, for me, alcoholism is the only disease that tells you you don't have it. And many times I went to my doctor, and I've told Evan this, and she'd give me a vitamin B shot, and off I'd go. I don't know that my doctor knew what to tell me. My kids did. And my kids are now 24 and 25, and we're battling getting our relationship back together. And their worst fear, I think, is that they've got the gene. So what I've learned is I have to have a program in place. I have sponsors. I have people I can call. I have to work a program. It's not just about abstaining from alcohol. It's behavior change. So I've had to look at my past behaviors. I have like these, my brain has a path of triggers. I know what triggers me now. And I have a toolbox that I learned when I was in for 6 weeks, every day, intense work on my behaviors, where my addiction came from, masking. I masked everything from being the only brown kid in school other than my brothers and sisters. Racism in Port Moody as a young kid. I mean, you mentioned 1958 up there. I went, oh, that's the year I was born. So it's things that I didn't realize I was masking with pot, with even substance abuse, sometimes with humor. All of these pieces are things that I had to learn that I will carry for the rest of my life. What I find is that it's not just abstaining. There's a program that goes along with what keeps me sober. And it's how do we address the whole umbrella of the fact that when somebody's ready, where do we send them? When they get, when they're in a shelter, what is the outreach once we get them in there and get them clean and sober? Where do they go from there? Do they have kids out in the system? Are they in the system? Have they come from an abusive home? I mean, there's all these pieces that it's like this umbrella of incredible dysfunction. So that's why, you know, I'm looking at this, and this is another huge piece to a much, much bigger problem.
And that ties in with housing too.
Absolutely. Absolutely. Affordable and accessible housing. Once you are clean and sober, where do you go?
And I'll just make one comment about that, because I think what Constance is referring to is something that I've really neglected in the addiction treatment world. Is I've talked a lot about medications and some of the structural things, the biological things. What these types of medications do is they can put those types of psychosocial interventions that are needed 100%. You can't do it without them, but they can give them a boost of steroids for sure, and really improve people's chances.
Lots of hands up
One
here.
and then two.
One here. Go ahead. And then
Methadone is, of course, very addictive itself.
Yeah.
And once you start taking methadone, it's harder to get off than it is to get off heroin.
Yeah.
What about Vivitrol and the other one you mentioned? Are they also addictive and very hard to get off?
Yeah. So the question is about some of these treatments are in themselves addictive. So methadone basically works in the same way as heroin, except it doesn't give you the euphoria or the rush, and you don't go on the nod. It sits on the receptor and activates it, but you go into withdrawal as soon as you stop taking it. It's a once-a-day medication, and it's a dangerous medication if it gets out on the street. I've personally treated a number of people who've come into this hospital having overdosed on methadone that they bought on the street. I don't see the ones that die in the field because they don't come to the emergency room. So Vivitrol is different. It goes to the receptor, and I'm not saying it's better. I'm saying it's different. Methadone is a very effective drug because what it does when it sits on that receptor is if people take heroin, they're not craving to use it, and if they do use it, they don't get the reward from it. The drawback is it's very addictive. If it gets diverted to the street, it's dangerous, and people, if they have to come off it, it's as bad or worse as coming off of heroin. So the question is, what about Vivitrol? Does it do the same? Vivitrol goes to the receptor and blocks it instead of activating it. And by blocking the receptor, when you stop taking it, after it's worked its way out of your system after a month, it doesn't induce any withdrawal. So it's non-addictive. So you could see like your young person who becomes addicted to OxyContin, and evidence-based medicine would say methadone's the best thing for them, and they'll probably be on methadone for decades, if not forever, having to go to the pharmacy every single day to get it. Difficult even to convince your doctor that you want to take methadone with you to Hawaii, let alone trying to get it through the airport. So obviously, for someone like that, a shot that they could come off of any time if they've got their act together and they're not going to be at risk of relapsing has huge potential for people. So good question, and
Lots of
it's different in
questions
that
here.
way. Sorry.
Sorry, gentleman here, and then this lady here, and then, sorry, I'm pointing. I can hear my mom, don't point. She's in my head. Go ahead.
Kevin, have you found any research that shows whether there's a correlation between income or socioeconomic status and success in getting out of addiction?
You know, I think the biggest predictors are the quality, you know, environment, biology, and then when it comes to treatment, you know, it's treatment system characteristics. So, you know, there's so many studies, and I could talk about tobacco, I could talk about alcohol, opioids. Cocaine is in a different category in that we don't have good treatments for it, although there are some. All the studies have shown that better than placebo, these medications give people a huge advantage in terms of all the various outcomes. Not using street drugs or alcohol anymore, becoming employed, not becoming incarcerated. Who gets these things? You know, what is the likelihood that someone that's living in an SRO in the downtown Eastside is going to get $18,000 to go to the Orchard?
Not likely.
Not likely.
No. One of the other things too is you need to want it, because there were people that were in the Orchard that were there 3 and 4 times. They didn't want to be there. Parents had sent them there. You need to want to get clean and sober. So at least it helps.
Yeah.
All right. We have another question. How effective has evidence-based research been guiding policy, public opinion? Question 1. Question 2, are there particular stakeholders most necessary to bring on board in order to influence change?
So, you know, I could just sort of give my personal opinion on that. In terms of evidence-based approaches, that's a fascination for me, actually, is the discordance between evidence and policy when it comes to drugs, but also things in general. My personal experience as being involved in the evaluation of Insight, which required going all the way to the federal Supreme Court to keep it open, and that was a unanimous federal Supreme Court decision, that was because of the research that decision came about. But it was a very oppositional thing with the federal government and Stephen Harper and those that were trying to keep it open. And I was at a lecture once where someone was describing the situation with climate change scientists in the US and how they had, with George Bush when he was first elected, tried to shame him into doing the right thing with climate change. And of course, he went on to describe how evangelical Christians in the United States, as part of their homeschooling curriculum, were teaching their kids that climate change was an idea created by the devil. So how you go about trying to use evidence to change policy, I think is really important. And quiet diplomacy and other measures, I think, can be useful. The case of Insight was successful, and that was a time when Harper had a minority government, and I think a lot of people thought that you know, people would be you know, not supportive of the position he was taking with Insight. But I think to answer your question, that's a good example of where evidence has been effective. The people trying to convince the federal government about the harms of mandatory minimum prison sentences and all the evidence around in that area was obviously not successful. The second question was?
Oh.
You might want to change the slide.
I passed it over. Did I
Was
pass
it here?
over? Yeah.
Sorry, I don't remember what the second question was. Oh, here it is. So who needs to be brought on board? That's a great question as well. And I think, you know, trying to make a compelling argument in terms of, you know, a human rights argument, for example, I think some people really respond to that. Other people will respond to the economic argument. Other people will respond to hearing from families. Other people will respond from, you know, all sorts of different things. And I think it's really important. I think in the drug prohibition debate, it's been extremely helpful to have police officers coming on board to talk about this issue. And that group, Law Enforcement Against Prohibition, has done an amazing job. So I think you need all these voices trying to work together to change minds.
Okay, and we have this lady here.
Your
presentation really reminded me of the journey of mental illness and how the stigma, the treatment, society's reactions to mental illness. Is there a close relationship between drug addiction and mental illness? And will treatment address those if there is?
Yeah. So I'm going to have a very unpopular answer to that.
Yes, it is.
Sorry. So the question was, mental illness and addiction, and is addiction a mental illness, and the stigma towards mental illness and how these things are blended together. It's my personal belief that the way the pendulum has swung to addiction and concurrent disorders and mental health and addiction, and the two are almost inseparable in our policy response. And addiction has become the ugly stepchild of mental illness that nobody wants to touch. So every time I hear about a big plan for mental health and addiction, I just think, oh no, it's going to disappear in the black hole that does not take this on. Now, your extremely unwell schizophrenic with heroin addiction needs mental health. They need psychiatry to come and help them. They need mental health teams to work with them. But for your average person in British Columbia that's struggling with addiction, they don't have those other issues. And your average psychiatrist will never prescribe methadone or get involved in the care of those patients. So I envision an addiction pillar that needs to be built to respond to the problem of untreated drug and alcohol addiction, and that you bolt on the things that were successful with HIV. You bolt on the response to severe mental illness that can help in the context of dual disordered people with mental health and addiction. But that's a very sort of, I believe, unpopular thing to say, because the convention is mental health and addiction. But I don't see where that's got us.
Okay. And the question behind, and then we'll go to these.
Well, I'm from Greek to Action, which is a family support and advocacy organization for a family member that is involved in mental health and addiction. But you're right, it is oftentimes just said mental health and addiction like that, and that's how it comes out. So I really hear that. My son started self-medicating, I think, and that's why he became addicted to opiates. And so now we're trying to unwind all of that. And I think that that's a really important piece. And the stigma for both mental health and addiction is so strong that we couldn't start by having any kind of conversation about it, because when I took him to mental health, they said, bring him back when he's clean. We're not going to talk to him now.
Yeah.
But what I really wanted to comment on was the holistic piece that you're doing, and the comment about how this has to include everything from really treating addiction as a health issue. It's not under health. It's not under the health department or the health ministry. It's and most of the places, they're all private. And people don't realize that, I don't think. The abstinent places as well as other places, but mostly it's abstinence, and it's they're very unregulated, very it's usually somebody that's been on the street and then has their own particular ideas about how to get somebody not to be addicted. And they're hardcore 12 steps or softcore 12 steps, but that's really all that's out there. And then afterwards, what's out there for a 20-year-old, for instance, my son went to one program, the Phoenix Center in Surrey, which was very good and very multidisciplinary, but none of these drugs or this kind of stuff is even in their radar.
Yeah.
And as a matter of fact, one of the places he went, in Revisions, they actually took some of his mental health medication away from him, because they won't even allow a Tylenol in the place.
Yeah.
But then he went to places like the recovery support houses, which have no staff, no facility operational requirements. There's 20 to 25 guys living in a duplex in a rundown area. There's 180 of them in Surrey. There's 130 of them in Coquitlam. Those are where people go after they've been in a treatment center, so-called treatment center. So people have really got to get their head around this. Is not even being treated remotely as a health issue. It's so good to see this presentation.
And I guess just my comment on that is people say, well, where are we going to get the money for this? And meanwhile, look at the money that we're hemorrhaging just in the emergency room here with soft tissue infections from people that are getting infection-related complications from drug injecting, the cost of the prisons and the police and everything else. So there's lots of money in the system.
Okay. We've got one more here. What's the expected recovery duration, if any, of the dopamine system, reward, to normalize after discontinuation of Oxycontin
So,
or heroin?
yeah. Yeah, so the actually recovery from opiate addiction, sorry, the question is about, you're hearing it, but for the microphone, for the video, the recovery time from opiate addiction, it's really the stimulant drugs like cocaine and methamphetamine that really seem to have a prolonged period before the dopamine system comes back. And for things like OxyContin and heroin, it's more the opioid system that then does trigger the dopamine system, but it doesn't. Opioids, it's a different animal, and it's not really the dopamine system. But the incredible reward and craving that people get from opioids, I've alluded to this article that was in the province this week, is talking about just sending people to abstinence-based treatment and putting money into abstinence-based treatment. And I could have shown the studies today. If you just look, you take people who are addicted to opioids and you randomize them to a Cadillac type of treatment like the Orchard, or Cadillac type treatment like the Orchard with methadone, or Suboxone is a similar medication, and the people that get Suboxone or methadone do dramatically better. Dramatically better. Like they don't even compare. So everyone should get an opportunity to go to an abstinence-based treatment, and that medication isn't rammed down their throat immediately. But your average person, when that doesn't work, will benefit from that type of medication.
There was a lady who had, there you are. Sorry, I'm just trying to remember. Go ahead.
So going back to
Oh,
what you were
and
talking
then-
about
and
with
then-
evidence-based research and the disconnect with policy and your experience with Insight in the Supreme Court, I'm wondering for the Naomi Project and prescription heroin in Vancouver, if you think that precedence will have an impact on how that plays out.
Yeah. So the question is about the heroin treatment research that's happened in the downtown Eastside. So as I said, heroin is a pharmaceutical trade name for an opiate medication, not very different than OxyContin or morphine or any of the other opioid drugs that we are all aware of. Studies have shown that for people who become addicted to street heroin and you try methadone or another medication like that and they fail, and they repeatedly fail, and they're in and out of jail and breaking into cars and causing all sorts of problems that makes them eligible to a prescription pharmaceutical supply of heroin, that those people do dramatically better in terms of their health and in terms of society's health, because it reduces criminality and other things. Now that's a medication that you have to take by injection 3 times a day in a clinic. So you think methadone once a day from a pharmacy is a burden, that's a huge burden as well. So that's what a heroin prescription program looks like. It's expensive, but it's effective for people that fail methadone. The question is, with the Insight experience and going to the federal Supreme Court to allow it to stay open, it's an unanswered question about the heroin prescription thing, because the Harper government actually provided a legal exemption to allow for this study to happen that's going on in the downtown Eastside right now. People may have seen the controversial decision by the federal health minister to not prevent the generic availability of OxyContin. She wrote a letter to all the health ministers saying it's not the federal government's job to decide what medications are available in the provinces. So I don't think we should assume that the federal government isn't going to allow something that they've already allowed to continue. But it may require going to the courts, and I think there's a discussion happening about whether that would be necessary. I'm not personally involved in that work, but I'm a supporter of what they're trying to do.
And the woman that was right in front?
I was wondering if you could comment on whether you see a relationship between kids that are diagnosed with ADHD
Yeah.
and addictions.
Yeah.
Because there's an explosion in recognition apparently of kids who have attention deficit hyperactivity disorder.
Yeah.
Repeat the question.
Thank you. Remind me
Thank
if
you.
you have to.
Repeat the question, just a little voice.
So the question was about attention deficit hyperactivity disorder, which is a increasingly common diagnosis with young people that they could put on stimulant medications to treat. It seems odd that by giving someone a stimulant, they'd be more controlled in their behavior in school, but for whatever reason, it works. There is a link between ADHD and addiction. And there is studies describing how people will be compelled to use a stimulant medication, a stimulant street drug, because of their untreated ADHD. So to answer your question, yes. Do I know that literature and the genetics of it all? I don't. I think this is a good example where I don't want to swing the pendulum so far that mental health isn't involved in these types of questions, because they certainly need to be. And I hope that answers your question. And this does need mental health support, but it needs people. Your average person taking care of someone with addiction isn't an internal medicine physician, isn't a psychiatrist. It's a family doctor that's taken an interest in this area. And I'd like to sort of empower that group and bring the others to the table as well to bring that for people that don't have ADHD, or avoid the situation where ADHD isn't diagnosed earlier.
Okay, one more written, which is, can you comment on Sensible BC?
Sure. So there's been a big debate in the province over the last approximate 1 year about cannabis policy in British Columbia. So I think everybody here knows that there's a huge cannabis industry in BC. All the grow ops and home invasions, hydro theft, it's like constant. So there is a group called Sensible BC, and what they're trying to do is to look what was done with the HST referendum and the repealing the HST through a ballot initiative, a mail-in ballot, and they want to do the same thing for cannabis policy in BC that would essentially make it decriminalize cannabis possession in BC. There's another organization that I'm affiliated with called Stop the Violence BC, which actually wants to promote the taxation and regulation of the adult use of marijuana and just take it out of the hands of organized crime altogether. They're trying to achieve the same goal, I think, but the question was about Sensible BC, and that's what they do.
Okay, we have one. I think you've answered this. What do you think of the Salone project? Is it beneficial? And what happens when the study ends?
Yeah, I think I answered that question.
Yes, and this is the same. So any more? Oh.
1, 2, 3, maybe.
Okay. Start here, and then here and here.
Question about that. So has there been an analysis on the economic impact on BC if they legalized marijuana? Take $7 billion of drug money out of the economy. How would that affect society? Is anyone knows that?
Yeah. So the question was, what would be the impact on BC if you took this $7 billion out of the economy? It's sort of like the question, well, I'll answer your question first. That's a number that the Fraser Institute, of all organizations, came up with in their report, which said we should tax and regulate the adult use of marijuana. The vast majority of that $7 billion is an export market to the United States. So until there's removal of that sucking demand for cannabis that has produced the market to the north of them, we can't really get rid of it. Unless we were to totally legalize marijuana here and start, shipping it across the border. Now, of course, there was always talk of the borders being sealed if BC were to change its cannabis policy, and we have now seen Washington State legalize marijuana. So I'll tell you that the impact of the Washington State legalization, according to the economists, is that it will shrink that $7 billion in BC because they'll be producing it domestically. There was a study done looking at domestic consumption of cannabis in BC and how much tax revenue could be raised, and it's somewhere around $2 to $2.5 billion of tax revenue in the first 5 years.
One of the things that happened when we started criminalizing drugs was that really exciting research into the medical uses of things like LSD and other hallucinogenic or psychoactives was cut off. And we're starting to see that coming back now. And I wonder if you could comment on both the effect that the criminalization has had on actual medical research and the promising research in those areas now.
Yeah. Yeah, so the question is, what about these psychoactive drugs like LSD, like ecstasy, that people were using before they were made illegal in psychotherapy and other things? I think the biggest victim of sort of medical research under prohibition has been medical marijuana. where the physician community is kind of going like, what do you want me to do with this? Like, I don't know if it works. I don't know what it does. I think there are some interesting studies that have been done, but they're few and far between. So it's difficult to know. In terms of the research in the use of things like LSD, there are now meta-analyses of randomized clinical trials looking at things like LSD for alcoholism, and they suggest that there's a benefit. And I think it's just hard to know, right? Something called cognitive behavioral therapy is a way of sitting down with someone and trying to change their way of thinking. And it works, but it's very difficult and it doesn't work on everybody. So if you can give something to someone that will open up their mind and make them thinking about their problems in a different way, there may be a benefit. I can't tell you if there is or if there isn't, because as you alluded to, the prohibition on researching these things has prevented us from answering those questions.
There was another hand up, I thought, on that side. No? No? Okay.
Just
Gentleman here?
you mentioned, there is a lot of information on the LSD analysis available now. And going back to dream work.
Yeah.
But I was going to say, is there any legal obligation for doctors to prevent the fetal alcohol syndrome? Have they got any power over that?
Yeah, so the question is about fetal alcohol syndrome and the role of physicians in that. That's a good question. I don't know the answer to that. I think in our society, and I don't want to say for sure, we give pregnant women a lot of autonomy over that type of stuff. It's different than in the United States, where people can be incarcerated when they're pregnant and they're using substances like that. Yeah.
Gentleman here and then in the back.
Can you maybe comment on pharmaceutical abuse and how that fits in a bit? Is it going up? Is it going down?
Yeah.
Medications like prescribed by doctors that are being used?
Yeah. I can share some of those stats if you want. Do you want to comment on your experience with your peers that you saw in the orchard in terms of?
You know, it was interesting because speaking about oxy, I had never heard of it before. And the women that were in and were absolutely addicted were women that had gone in for facelifts, nose jobs, and had been prescribed oxy for the pain. And these women were actually not wanting to be there. They just loved their new nose, but were addicted and were doing anything to basically escape, to get down to the downtown east side to buy heroin. There were a lot of kids that had been using oxy and different drugs, grinding them up, and these were kids from private schools. And I think, again, for me, it was that whole stigma of what somebody that's addicted to drugs or alcohol looks like. So for the prescription drugs, I found it really interesting to see the people, and I speak of the orchard, but I've also had the opportunity to go into some of the shelters in the downtown east side, the one on Seymour, where we have the heat shelters that the city has created. And you see people that are there that are addicted to street drugs or prescription drugs, and they're buying them on the street. So you've got people that are actually parents that have prescriptions. The kids are stealing the prescriptions and going out to the street and selling those prescription drugs, which feeds their habit. And again, I think it's just a vicious circle, and what we're not doing is when we have the people in the shelters, you talked about affordable housing, when we have the opportunity to do outreach, that's, in my opinion, where we need to be reaching out to the youth, to the people that are getting the affordable housing, that are in the shelters. A perfect example was, it was snowy and it was the shelter down by Emery Barnes Park, and there was this all controversy about the Emery Barnes Park people, and they didn't want the shelter. And I went and I talked to the people, and these were young girls, my daughter's age. Thank my lucky stars, neither one of my children have addiction at this point, because it didn't hit me until I was in my 40s. But these are young people with children that have been taken away. Their kids are in the system. So when I finally start talking to them, they said, you know, I'm asking because my daughter's in the system. Social services took her away. And it's this vicious circle, because the kids that are out there in the system, they're going to grow up dysfunctional. They feel like they're going from home to home to home, to foster parent, and they're going to start using because they're masking that they didn't have a mom. So again, you know, to answer your question, it's across the board. I think the prescriptions are handed out far too easily these days. I don't feel like they're monitored. If you're going in and you're saying to your doctor, I went into my doctor because I'd have panic attacks when I didn't drink and I tried to stop, and she'd give me Ativan. So then I'd have Ativan and I'd be all relaxed and have a cocktail. So you got the Ativan and a cocktail, then smoke a joint and go, oh, is that a lie? You know, I mean, it's just this vicious circle that I don't know that my doctor knew what to do. I don't think that she knew how to approach me. And in all honesty, I don't know that if she would have said anything to me, I would have actually listened. So it's a struggle because I mean, this gentleman is far and few between. Dr. Fay, Patrick Fay, who works out of the Orchard and has a place over on Commercial, is 1 in a million that he gets addiction, and that's all he does. But it is far and few between to find a doctor that feels comfortable. Like we said, if you've got some kind of an allergy or you've got a disease, you can Google it and look. Mm-hmm. But for a doctor to be able to say, okay, here's what this addiction is, here's what you do, here's the next step. You know, here's kind of the map of steps that we need to do to assist this person. It just doesn't seem like it's out there, you know.
It's not out there. I work in, the shelter system, and I watch people go through the harm production for years, using hundreds, thousands of needles going out.
Yeah.
Which is horrifying. To a certain degree, it's life-saving, but it's also, they end up with viruses in their heart and on antibiotics for months at a time, and only 24 years old losing their teeth.
Yeah. Yeah.
I'm like, okay, what comes next? Because, there's a housing problem, number one, and then people go into these treatment centers or detox, they get on medical detox, and then they go through a detox program for like a week, and then they're back at the shelter.
Yeah.
So so I'm like, people want to get into detox and will, support that and hold their bed, and then they come back and we see the cycle kind of continue where they're now juggling methadone and the street drugs and homelessness, and I suppose there's probably some kind of a solution that and finding the right treatment that we can refer people to or to a detox is really challenging at every turn. I mean, it's really challenging. We get people to call them, Vancouver Detox or the hotline, and it's really a struggle for thousands of people. I would say it's really pressing.
There needs to be a lot more support. Perfect example is the Rainier. The Rainier, you've got amazing women that are all clean and sober, and the cut budgets. Sorry, this project is done. It's been fabulous. It's over. Yeah. So they've lost a huge amount of support in there, and these women are all clean and sober, and they've been there, and they're ready for their next steps. And the cuts have just kind of they've taken the food out of their mouths, really.
Right. So there's the need for low barrier detox and treatment where people are accepted back and they don't lose their housing just because they've relapsed. And they can kind of work in a stable housing situation with their problems. It's really a struggle.
Okay, thank you. Lady in the back. And if you could just speak up so we could repeat the question, please.
Wondering how about alcohol addiction, because I don't think ethanol, like cocaine and heroin, actually crosses the blood-brain barrier, so it can't access the dopamine pathway. So how does that happen as compared to cocaine?
Yeah, alcohol does actually crosses all cells in our body. Yeah.
One more.
So I am in end-of-life care, and of course we're kind of getting that swing pendulum the other way in terms of opioids, where we just can't get the amount that we need, we can't get the doses we need, we can't get them overnight. How can we work with physicians to sort of educate that group, and also I guess pretty much everyone who's reading all of these horror stories in the paper about appropriate prescriptions?
Yeah.
How do we make
Yeah, so I was in the downtown.
Repeat the question.
Yeah, sorry. So the question is about undertreated pain and opiate addiction. And I was in the downtown Eastside earlier this week, meeting with a group, an advocacy group, and a woman there was telling me about her breast cancer and how painful it is and how she can't get pain medication. And I alluded to this when I talked about OxyContin, is that we have a huge problem with undertreated pain in our society. And then, you know, you have this huge problem, as Constance has described, with diversion of these medications. There's a question earlier about prescription drugs, and that whole phenomenon, the huge epidemic and overdose deaths, is really largely attributable to the company that pushed OxyContin out. So Purdue is the name of the company, and it's been really well described how they believed, or they wanted everyone to believe, that that drug was less addictive. It's a long-acting medication, so shorter-acting medications that bring you up and down traditionally are felt to be more addictive. But clearly there is something about OxyContin that gives people a very special reward. And Purdue was in family doctors' offices saying it's safe, it's non-addictive or less addictive than traditional painkillers, and really pushing it out there. Lots of free samples for physicians, and it spawned this whole problem with OxyContin. Now, there's other opioids that get to the street, and your average physician is faced with, can I trust this person? Can I adequately treat their pain? A lot of these overdose deaths are people who are just dealing with a knee surgery. And, you know, you can imagine some tough guy who goes and drinks a bunch of beers and his knee still hurts, so he pops another OxyContin. Well, alcohol plus opioids is a huge risk factor for overdose death. So these overdose deaths are happening to people after surgery. They're not just street-obtained opioids. So it's a huge challenge. And then on the other hand, you have this woman who's got severe cancer pain and she can't get treated. You've got people in palliative care and difficulty getting pain medications to them. So you're describing a very difficult challenge, and I agree with you. I don't know what the solution is. There are things like medical databases, like the PharmaNet database, that has been underutilized for physicians to see, well, actually, you got a prescription for OxyContin yesterday from someone else. Where did all that go? And there's ways of doing a better job and trying to put the genie back in the bottle. But it's a balance between adequately treating people's pain and keeping these medications away from people who don't need them.
Gentlemen, right here.
I was going to say, in addition to that, one of the problems with chronic pain from a family doctor's perspective is you're being paid fee for service when there's so your computations for your clinic every 5-10 minutes, right? And you have a chronic pain patient comes in, a chronic pain patient takes, you're right, it will take you 20 minutes, 25 minutes, and most doctors don't do that. They don't really, like you said, we don't get a lot of education on that addiction in residency as much as we should. So one of the ways that they combat that is the College of Physicians and Surgeons will go and review prescriptions on physicians who have high numbers. And so it doesn't matter if it's prescribed for chronic pain or end-of-life care or whatever it is. They look at full numbers, and there's a little bit of a leash on doctors. The college will call them in to review them for that. That's about the only leash there is on that.
Yeah. So the comment is about how these databases are used by the College of Physicians and Surgeons, but we sometimes live in fear of them. Because you're like, well, this person clearly, it's, they have a GP who's taking care of them in the home, and I'm not worried about diversion at all. But then you're thinking in the back of your mind, am I get the college coming and snooping around and giving me a hard time? So there's no easy answer to it.
Any other questions? One and one?
Do you still prescribe the AA organization that's all in treatment? The therapy, AA?
Yeah. Yeah, so the question is about Alcoholics Anonymous, and there's also Narcotics Anonymous. It's really interesting and controversial because the studies that have really compared people that get randomized to AA to other things, the people that get randomized to AA may not do better. But the people that continue to go to AA do well. So I think AA has helped thousands and thousands of people. And when we're talking about a system where there's almost nothing, but there may be an AA meeting in this hospital tonight, because they're everywhere, and there is a group that meets in this hospital, to have it as a tool, I think it's very useful. But should we, run with AA? Not necessarily so.
And
Could you just comment quickly on medical marijuana as something to help with opiate addiction?
Yeah. So the question is about using medical marijuana to help with opioid addiction, and it's interesting because I've been involved in trying to promote a taxation and regulation approach to recreational marijuana, and I get a lot of questions about medical marijuana, and I don't know anything about it. However, I do know that there are people, and there's a guy at the Centre for Addictions Research BC in Victoria who has published on this, talking about how people start using cannabis and will get away from more harmful types of substance use like alcohol or opioids. So I think it's intriguing. I don't know much about it. There are people that talk about that. Yeah. Should we say last question?
last question. Yay, you get the last question.
Thank you. I know there's known to be a connection between price of tobacco and youth smoking.
Yeah.
Are there similar connections between price and youth addiction in alcohol and other drugs?
Yeah. So minimum pricing for alcohol and certainly pricing for tobacco has a huge impact on rates of use. It's very difficult to try to control the price of street drugs. And as I've showed you, it doesn't matter if it's heroin, as I showed, the graph looks the same for cocaine and for marijuana. The price has tended to go down over time, and the potency has tended to go up. So trying to control the market like that, it's just been too profitable. But in terms of controls, when you think of that U-shaped curve with legalization or a prohibition and regulation in the middle, in the case of tobacco, I think you're searching for a sweet spot. And with tobacco, it's been so taxed and regulated that you start to see contraband tobacco emerging. And I think that's the sweet spot. You want to get right there to where you're just at risk of an illegal market emerging from a public health perspective. If you're trying to, rub your pennies together to buy a carton of smokes, it's a little harder. But from a public health perspective, that's how you try and find that regulatory sweet spot, I think. When something's prohibited, you can't do that. Thank you, everybody, for coming tonight.
Thank you.